Assalamu alaikum, مساء الخير. Good evening, everybody. My name is Ibrahim Sweih. I'm a neurosurgeon, and we are transmitting live to our international audience from the Farah Medical Campus here in Amman, Jordan. The topic for tonight is going to be spectrum of the CNS lesions in Scleroderma. Just a brief introduction that we're talking about connective tissue disease, which includes more than 200 disorders. And connective tissue disease means any disease that affects the connective tissue, obviously from the name. And here we're affecting the collagen and the elastin in any structure like joints, bones, cartilage, ligaments, tendons, muscles, skin, eyes, internal organs in general. So this is some examples of the connective tissue disorders: ankylosing spondylitis, Lyme disease, Behçet disease, sarcoidosis. If we take a specific group of connective tissue disease, which is the autoimmune connective tissue disease, includes diseases that are known to you: rheumatoid arthritis, psoriatic arthritis, SLE, scleroderma, polymyositis, dermatomyositis, granulomatosis, vasculitis, Marfan syndrome, Sherk-Strauss syndrome, undifferentiated connective tissue disease, and mixed connective tissue disease. The etiology of this immune connective tissue disease, usually there is some underlying genetic predisposition, and then there is a second hit that flare things up, like trauma, radiation, viral infection, exposure to chemicals, medications, and then the whole thing starts. And when it starts, it will cause endothelial cell injury, and that will secrete chemokines and interleukins, and these will produce inflammatory action using T helper cells, and the interleukin also will aggravate the situation, and then we activate the fibroblast. That's why the name is Scleroderma, because it is made of fibroblasts. And to detect these, you will find anti-nuclear antibodies, ANA, and these are the antibodies that are attacking and binding to the cell nucleus. That's why it's called anti-nuclear, because it attacks the nucleus. So many of these antibodies. And titers, I always say that whoever prepared the lecture gets the most benefit, and I've got benefit of knowing always what's a titer. Titer is the highest dilution of serum at which antibodies are detected. So it's 1/160 or higher. So in Scleroderma, you would find ESR elevated, rheumatoid factor positive in 40% of cases, ANA positive in 40 to 95% of cases, and antibodies are there. Of course, the different types of sclerosis would dictate what's the percentage. And how you detect the ANA? By indirect immunofluorescence or by ELISA, which is the enzyme-linked immunosorbent assay. I also looked and benefited myself from seeing what is this immunofluorescence. This is the immunofluorescence, and you can see deposits of IgG in the endothelium of tissues, like this one. So, without any more introduction, I'll ask Dr. Hassan Daf to give us a brief about this disease.
It's very interesting to hear a neurosurgeon talking about rheumatology. The term connective tissue disease is now obsolete. It's no more used. It is rheumatological diseases, and there is the other thing about the titer of ANA. There is a new criteria in last year by the European League against Rheumatism, and the titer they put is 1/80. The previous criteria was 1/160, and the new criteria is 1/80.
ANA being positive.
ANA more than 1/80 now.
Yes, for a while, not just now.
Yeah.
No, the previous criteria was 1/160.
For 1 in 80.
1/80 is the new criteria last year.
Anything over 1.
So about scleroderma, it is either localized or systemic. Localized is linear scleroderma and morphia. Usually, these patients present to dermatology clinic. And the systemic is diffuse cutaneous, limited cutaneous, and the well-known, usually they ask in the exam for the residents, is the Christ syndrome. Calcinosis, rhinoid phenomena, esophageal hypomotility, and telangiectasia. And scleroderma-like syndrome and overlap syndrome. This replaces the old terminology of mixed connective tissue disease. It is again not used again. It is overlap syndrome now.
Systemic.
No, the systemic is multisystem fibrosis. Usually involve lungs, heart, GI, and renal. The renal is the renal crisis. Usually, in the early stage of scleroderma, when they are giving steroids, they develop usually renal crisis in the form of microangiopathic hemolytic anemia, severe hypertension, and the treatment is the old medication, captopril. Soft tissue calcification, arthritis, and small vessel stenosis. This is the linear scleroderma. And 90% of patients with scleroderma, they will have rhinoid phenomena. Rhinoid phenomena is triphasic change in the color of the hand. And it is usually white, blue, and red. It should be white, blue, and red. This is the sequence of rhinoid phenomena. White, okay. That's
How common is rhinoid?
90% of the scleroderma, usually they will have rhinoid phenomena. There's another rhinoid. That's rhinoid. Okay. And scleroderma usually 3 stages. The early stage is the edematous phase, and then the hand will be normal, and then the fibrosis. This edematous stage usually responds to small dose steroids, and the other one is the advanced picture. Calcification, pulmonary fibrosis. This is a picture of pulmonary fibrosis. It is not rare, it's common. CT scan of pulmonary fibrosis. Esophageal dilatation and hypomotility of the esophagus. That's another feature. Okay. That's your slide. But usually the GI involvement down, it is characterized by wide mouth diverticulae. And usually this will cause malabsorption syndrome. Okay. There is some high risk of malignancy in these patients. 2 large studies from Australia and Europe showed increased risk of lung cancer, hematological malignancies, bladder cancer, usually because of cyclophosphamide. Cyclophosphamide causes hemorrhagic cystitis and may cause bladder cancer, skin cancer, and esophageal malignancy. Breast cancer, there is no increase in the risk. This is cancer lung, and this is esophageal carcinoma. Should we screen these patients for malignancy? The answer is as age-appropriate screening. There is no guidelines to screen these patients, so we screen them as normal population at that age. Okay.
Thank you. So after this introduction, we'll go into further details. So the topic is scleroderma, and we said that it's an autoimmune connective tissue disease, and it's the position of collagen and extracellular proteins. So there will be scar tissue, sclerotic lesions, that's why scleroderma from sclerotic, in the skin and the internal organs in the blood and the blood vessels. Female more than males, lucky us, and it is more in blacks. So morphia, which Dr. Nadaf alluded to, could be linear, could be circumscribed. Mostly this is seen in children, circumscribed is seen more in adults. There is no mortality, major mortality or major mortality percentages in morphia, but in systemic sclerosis, there is high mortality. So that's the difference between a localized and a systemic one. Again, autoimmune, so should be doing CSF studies. You will find oligoclonal bands, elevated IgG. And the organs involved here are skin, as Dr. Nadaf mentioned. So this is the linear one. And you can see it there and there. As I said, linear is more in children.
Are they born that way or it just develops with time?
It's sclerotic. Sometimes there is some depression in the skin underneath. Alopecia. Look at these skin lesions. So skin can be involved. It's just a reminder for us to look during examination into these things. We really stopped doing that, and I always say that we practice medicine with very, very little knowledge. We should go back to the roots and examine the patient thoroughly. So these are the things that you look for in the back and the trunk and the arms and so on. Joints, as Dr. Nadaf mentioned, 3 stages, the swelling first, and then there is the major degenerative changes inside, and it can affect the apophyseal joints of the spine, like this, and cause spinal canal stenosis. Can affect CNS, and this is the interest of us today. And what are the CNS pathologies in scleroderma? There'll be changes in the blood vessels. We mentioned this is autoimmune, and there'll be calcifications, there'll be perivascular infiltrates, and there's a picture of vasculitis. So this is some of the examples of the lesions that they took biopsy from, and look what they found. Cortical necrosis, lymphocytic vasculopathy, vascular thrombosis. So all this in this disease can affect the CNS. And as a result, you will have headaches. And look at this, 18 to about 50% of patients with scleroderma will have neurological involvement. Epilepsy, movement disorders, focal deficits, neuropsychiatric disorders, vasculitis, and the ischemic and vascular lesions. Examples. This is for number 1. It can cause atrophy of the skin and the bone underneath. So the skin is atrophic, fibrotic edges, and the bone is also atrophic. And this is from Harvard Medical School. Mentioned in this case, look at the bone here, and look at the bone here, look at the soft tissue here, and the soft tissue here. Again, compare this bone with this, compare the skin also. So atrophy of the skin and the underlying tissue. And usually, if you have these lesions, the CNS lesions are on the same side. But rarely they can be both sides. But most of the time it is on the same side like the skin lesion. Look at this here, hippocampus is okay, here it's atrophic. And atrophy of the hippocampus takes you into so many syndromes, including dementia. There could be calcification. Again, you can see it here. And the linear scleroderma. And you can find brain changes. These are called subcortical and white matter hyperintensities. Look at these. And most of the time when we look at these, we say, oh, this is age-related changes, cerebrovascular disease. You dismiss it as normal for the age. It could be multiple sclerosis, it could be this. So don't dismiss anything. White matter, hyperintensities. Again, look at this. This is actually common finding in our whole population that we see it. Basal ganglia involvement, usually bilateral. And again, basal ganglia, we say this is all parasitic infection as a child, and so on and so forth. It can affect the medulla and pons and midbrain with major sequelae. It can cause patchy enhancement like this, here and there. Again, you see patchy enhancement and don't know what it is. If you see these, this could be vasculitis. Sulci enhancement, the sulci are enhanced. There could be hemorrhage because the vessels are affected, as we said, either occluded or there is lymphocytic proliferation, so they can present with hemorrhage. And this could be localized or generalized. Again, here, scleroderma presenting with recurrent episodes of brain hemorrhage. This is from Japan. There could be petechial hemorrhages like this. And again, we may think of AVM here. And people, including Parry-Romberg syndrome, as you cannot separate Parry-Romberg syndrome from scleroderma. Still, people separate them, but most of people, they put them together. There is hemiatrophy of the face, and also hemiatrophy of the brain, and hemiatrophy of the vessels. They can present like tumors. Scleroderma presenting with CNS like tumors. That's why it's called tumefactive. Look at this, like a tumor. Again, you can see different presentation of these lesions in the scleroderma. They can present as well vasculitis appearance. So progressive hemifacial atrophy, or Parry-Romberg syndrome, this was discovered 1890 something, so it's an old syndrome, but it was not included in the spectrum of localized scleroderma. Here you are, hemifacial atrophy. One side of the face is atrophic than the other. Look at this, as a child, and it's progressed. This is from Germany. And this here. You can see there's even atrophy of the maxillary sinus. So also it can affect the ophthalmological system, mitosis, exophthalmitis, uveitis, so many papillitis, and so many other lesions. This is, look at this, changes inside the sclera, atrophic, papilledema, and changes of, like this, loss of pigment there. Look at the left orbit, it's atrophic. So this is really multi-system disease. Here in the mouth, in the oral system, they can present with altered dentition, malocclusion, or tongue atrophy. In this case, there is the C atrophy. Again, here I want to call upon Dr. Hassan to discuss a certain case that we had together for some time.
Thank you for this nice CNS manifestation of scleroderma. Neurosurgery. Regarding the periventricular lesions, which Dr. Ibrahim showed, it is not unique to scleroderma only. It is seen in most of the connective tissue disease, the rheumatological disease, including vasculitis, including Behçet syndrome, including antiphospholipid antibody syndrome. So we'll go back to our patient. She's 36-year-old Jordanian. She presented to me back in 2012 with 3 months history of Raynaud's phenomena. As we mentioned, Raynaud is present in 90% of these patients. Polyarthralgia of small and large joints, painless mouth ulcers, and the examination showed tender proximal interpharyngeal joints and metacarbopharyngeal joints. So the differential here is a little wide, including rheumatoid, SLE, among others. Her CBC was normal, ESR 40, Her RF is negative and anti-CCB is negative. So if RF and anti-CCB are negative both, this almost exclude rheumatoid. ANA is positive at a high titer, 1/320, double-stranded DNA negative, and the urine protein was 100. And the normal, as you know, is less than 300. So this is a positive ANA, polyarthralgia, Raynaud's phenomena. The anticardiolipin antibody was positive, IgG positive, and beta-2 glycoprotein IgG is also positive. So the diagnosis at that time is SLE with secondary antiphospholipid antibody syndrome based on polyarthral joint pain, painless mouth ulcer. Painless mouth ulcer is one of the criteria of SLE. And the positive ANA and the positive anticardiolipin antibody. So the standard treatment is hydroxychloroquine, the dose is 200 milligrams twice daily, prednisolone initially 10 milligrams twice daily, and diclofenac. So 1 year later, when she came for follow-up, there was difficulty making a fist. Difficulty making a fist usually is a tenosynovitis. Tenosynovitis of flexor tendons. There is evidence of sclerodactyly, as shown by absence of creases and facial tightness. She starts showing some features of scleroderma with decreased mouth opening. The normal mouth opening, by the way, is you can put 3 fingers in your mouth. If it is less than 3 fingers, this is decreased mouth opening. And she has gastroesophageal reflux disease. Repeat ANA is positive, ANA again, DNA negative, urine 80 milligram, anticardiolipin antibody and beta-2 glycoprotein came negative. In the criteria of antiphospholipid antibody, the test should be repeated after 3 months. If it persists more than 3 months, that means it is transient. So her antiphospholipid profile is negative again. Extracerebronuclear antigen, positive RNB, ribonucleoprotein antibodies, which is seen in overlap syndrome, and positive scleroderma 70. This is seen in 30% of patients with scleroderma. Her barium swallow showed dilated esophagus with sluggish motility, and high resolution CT scan of chest was normal. So, diagnosis now is overlap syndrome of scleroderma and SLE. She was started on methotrexate 12.5 milligram weekly. This is a small dose. Hydroxychloroquine was stopped because of skin hyperpigmentation. One of the common side effects for hydroxychloroquine is skin pigmentation. And especially in females, it is troublesome. So hydroxychloroquine was stopped because of skin hyperpigmentation. Prednisolone at that stage was only 5 milligram. Low VAS calcium channel blocker for her Raynaud's phenomena, aspirin and Nexium. So with methotrexate, she got pregnant while on methotrexate.
It's not
patient. It's not. Anyway, patients, when we start patient on methotrexate, usually we advise them to stop the medication 3 to 6 months prior to conception. Even in males, if a male is on methotrexate and the wife will get pregnant, usually we ask the male also to stop methotrexate 3 to 6 months before. However, the dose we use in rheumatology is too small to cause side effects on the baby. So we don't advise abortion, okay? And she delivered normal, healthy boy. Last visit in 2017, she was well. Meanwhile, because of some financial problems, she was followed at Islamic hospital. And the rheumatologist there advised her to change the medication to miclophenolate. At that time, she complained of headache to the rheumatologist. And because the miclophenolate is expensive, she was referred to Al-Bashir Hospital. There, they did MRI, and the story started here with Dr.
The pregnancy, what effect does it have on her symptoms? Does it improve? Does it?
You mean patients with rheumatoid will start with rheumatoid. Rheumatoid usually improve with pregnancy, and even we stop all medications. SLE and scleroderma pregnancy will flare up. Okay.
Thank you. Can I just one question?
Sure. Please.
From our experience, you said that the chest CT is normal. From our experience, that once you have dilated esophagus, the changes in the lung do precede that. Was it done high resolution or
It was high resolution, yes.
and normal?
No.
From our experience, always when you have dilated esophagus, you have fibrotic changes in both lung bases.
You are right, and even one of the slides usually in the exams is the patient with dilated esophagus and pulmonary fibrosis. What's your diagnosis? Scleroderma. Okay.
So this is a 36-year-old patient, and she's been diagnosed for some time, for 4 or 5 years, followed by Dr. Nadaf as scleroderma, and now she got worse with headache, and MRI was done. So this is the dilemma for tonight. What would you do with such a patient? So she complained of lack of concentration, forgetfulness, nervousness, irritability, mood swings, abnormal behavior. All this denotes frontal lobe changes. It's called frontal lobish behavior. She also developed left-sided weakness. She was incontinent of urine and feces. She got bouts of severe headaches, started having visual hallucination, which is epileptogenic in nature, and absence attacks. So she had epilepsy too. Examination. This is lower limbs. She had weakness, 2, 3 over 5, and plantar response was upgoing. So all this shows she has upper motor neuron lesion. She has got a brain lesion. Same thing with the upper limbs. On the left side, she had 3 over 5 weakness, and her reflexes were brisk. Again, this is upper motor neuron lesion, denoting the brain lesion. And with the frontal lobish, you can pinpoint that this is a frontal lobe lesion. And here I must stop and say how much I admire our fathers and forefathers of neurosurgery, diagnosing these things without CT, without MRI, without anything. I remember with the great affection, people like Dr. Saad Maraka, God preserve his soul, and we can't operating on patients just by the clinical hunch, without CT and MRI. Remember those days. So this patient was almost drowsy. To me, she was herniating, in a stage of herniation. She never could walk unaided, very difficult. And she had facial weakness. We continued the investigations. Liver functions were normal. Hemoglobin was low. Kidney functions were normal. And total ion binding capacity, ion serum, and ferritin were normal. Vitamin B12 and folate were normal. And lupus anticoagulant was 31.2. Is this high or low?
No, it's normal.
This is normal. So this is efficacy of the treatment?
No, as I mentioned, her phospholipid profile reverted to normal.
Right. Anti-beta glycoproteins, IgG, and anti-beta glycoprotein, IgM, were within normal. Anti-cadolipin, again, was normal. Because she came to us as a new patient, so we have to investigate fully. And anti-cadolipin also is normal. Images. What would you find here? This is a patient with scleroderma with all the CNS lesions that can she have, and she presented with this.
Wow.
What is this? Is this related to her disease, or is this something else? That's why the collaboration and the knowledge is important. People say, why would you know about this? Because this is a case that you will face one day. So this is the lesion, and you can see the amount of shift. This patient is dying. She is in a stage of herniation. She will die anytime. This is major herniation. With contrast, some contrast enhancement with cystic part. But again, you can appreciate the push of midline. T2 showing edema, extensive edema. So the lesion and the edema caused this syndrome. Again, you can appreciate the edema, and you can appreciate that there's some septae inside. Coronal, look at this subfarcine herniation. Subfarcine herniation is going to be followed by temporal lobe herniation through the hiatus and ankle herniation, and then there is herniation of the tonsils through the foramen magnum, and death, of course, once she reaches to that point. Solid part, cystic part, and so on. This is the sagittal. So, what is this? You ask yourself, what should I do? Is this something that I can treat with medicine? Is it this is systemic lupus lesions that we can refer to the rheumatologist to treat, or is this something that we need to operate? Obviously, you need to operate because there is a major shift. But what's next? What's your diagnosis? You have to have a plan. So what's the differential diagnosis here? The first thing you think of, tumefactive form of scleroderma. They present like tumors. So could this be tumefactive form of scleroderma? Again, tumefactive form of scleroderma. And remember the words of Dr. Nadar, that there is high risk of cancer in these cases. Are we dealing with some cancer in her body with metastasis to the brain? We don't know. So the differential diagnosis is really wide. And he mentioned the two large series in Australia and Europe. Although the risk was more to the lung and breast, but the risk is there. It could be something else, not related to the lesions of scleroderma, astrocytoma. And I put the lesions that look like our lesion. Oligodendroglioma. Oligoastro, although this terminology has finished a long time ago, but this case was diagnosed as oligoastro at that time. A glioblastoma, ganglioglioma. This is exactly like our lesion. DNET, desmoplastic and neuroepithelial tumor, primary neuroectodermal tumor, DNET. Or could this be a meningioma? Some forms of meningioma are called cystic meningioma. Could that be? This is one of my patients. I never knew that this is meningioma until I took it out. Cystic meningiomas. Don't forget this subgroup of meningiomas. Small tiny nodule and the large cyst. Again, meningioma, cystic meningiomas. Rhabdoid meningioma, not cystic, rhabdoid. Again, this is a malignant meningioma, one patient of mine. Looks like the same lesion. This is histologically proven. It's not science fiction. Again, meningioma, malignant one in this patient. And this is post-op, so this is histologically proven. This was a meningioma. Hemangiopericytoma looks very much like meningiomas. Metastasis. So could this lady have had cancer due to her scleroderma, and are we dealing with metastasis? Epidermoid. Again, this lesion, I've never thought of as epidermoid. I went in as a tumor. It's against all the radiographic appearance of epidermoid. Yet, sorry? Without diffusion. It's against everything. So I was really amazed that this turned out to be an epidermoid. Lymphoma. This is a patient of mine. MS, multiple sclerosis. We don't think of tumefactive form of MS, though we should. We're only looking for periventricular lesions in the brain or the spinal cord. We're forgetting about this subtype of multiple sclerosis. It looks like a tumor, tumefactive. And there is some subtype of it the shoulder disease, where you have the so-called part of the lesion is the contrast enhancement. Brain abscess. This looks like our lesion. Tuberculous abscess. Neurocysticercosis. Intracerebral hemorrhage. AVM. Sinus thrombosis. Superficial sinus thrombosis could present with unilateral or bilateral lesions. And again, I know of cases in Jordan were operated as a tumors, though they were just superior sagittal sinus thrombosis, simply because the neurosurgeon did not know about this. He never saw in his life a case of superior sagittal sinus thrombosis. He never consulted a neurologist.
So like, this is superior sagittal sinus thrombosis or part of the
A part, of course. Of course. It could be even cortical vein thrombosis, sure. Cortical vein occlusion like this. Radiation necrosis happening 1 year, 2 years, 10 years, 20 years after radiation. 20 years. I've seen cases like this. So the differential diagnosis is really wide. We did a few consultations. We asked Dr. Zaid Mahadin then to see the patient. He did EEG. She was epileptic. So that explained her behavior. Dr. Hassan Jayusi, ophthalmologist, saw her and he said she had bilateral papilledema, right more than the left. We consulted Dr. Ala Addashi. Could this be metastasis? So he said, let's do further investigation. We did chest, abdomen, and pelvis. It was negative. And we consulted at that time, this case was done at Jordan Hospital a few years back, and I consulted Dr. Mawiya Ababni to see her. Mawiya, could you please?
Thank you very much, Ibrahim. This is not an ordinary case, to be honest. It was a very difficult, tough case. And I hope, I'm just going to allude to what's related to me to anesthesia, what we've done with this lady. Lots of things to take in consideration. I mean, most of them have been mentioned by Dr. Nadab, by Dr. Ibrahim, but usually most of them are difficult airway. And when they are not just difficult airway, they are at risk of aspiration. As Dr. Nadab mentioned, already this lady, she had dilated esophagus and prone to regurgitation and immediately. And to make it even worse, difficult to intubate, takes time. So this, with respiratory fibrosis, so there is cocktail of disaster for her right at the beginning, to kill her right at the beginning for aesthetics. So I've got all risk factors combined there to finish the anesthesia right at the beginning of it. It's multi-system disease. It has been shown, and this lady was multi-system, cardiovascular, respiratory, renal failure. He just alluded, Dr. Nadab, to renal crisis, and I will never forget the renal crisis when I was doing house officer لما كنت امتياز، كنت مع الدكتور بديع الصالح ربنا يطول عمره. فدخلت مريضة إله وأنا كنت الامتياز مشرف عليها، بعدين أعطاها دوزز قال لي ستيرويدز ولا وات ايفر وروح، وبعدين قال لي روح شوفها وطمني عليها. شفتها she was not very well, but I thought she is fine. بس طبعا to my limited knowledge or ignorance at that time, I phoned him and told him she is fine. 2 hours later she was dead. And I hope everybody will imagine myself phoning him after 2 hours after I told him that she's fine, your patient is dead. She was 37. So I will never forget that thing in my life. I mean, that really was the problem. Skin consequences of for us is contracture. Again, difficult vascular access from all point of view. So we need ultrasound guided for arterial line. Skin is tough, veins are tough, arteries are tough. So it has to be done guided, and sometimes as well, probably you think really hard whether you want to do arterial line for invasive monitor or not, because already she complains of Raynaud's, already she has a problem with her blood vessels, but nonetheless, sometimes you have to wait. I really need to monitor her beat by beat, minute by minute, second by second, so I have to do it. And it's really a problem. lots of medication. She was on lots of medication. My goals were to secure airway safely and to avoid aspiration. And the best thing for these people, you need fiber optic and a quick, slick fiber optic technique to intubate the patients. Otherwise, because they are difficult, they've got small mouth, they've got restricted opening, neck rigidity, everything as I mentioned earlier. I've got the esophagus to worry about, regurgitation, aspiration. So probably fiber optic is the best option. I'm telling my colleagues, anesthetic colleagues, if you are good at fiber optic, you can do it within less than 30 seconds, good pre-oxygenation without anything. And that's what I've done for this lady. Am I going up? Vasoconstriction. I have to avoid, I mean, sometimes there is no one size fits all for anesthesia. And I'm going to ask all my colleagues, especially physicians, when they will write to me, this patient is not for GA, fit for epidural. He have no idea what's the great problem he puts in myself in front of the patient, trying to argue him. He is not fit for epidural. General anesthetic nowadays is one of the safest. There's no patient is contraindicated for general anesthesia. Trust me, not a single nowadays. Anesthesia is so safe. Drugs are so smart. They are so good. And there is no patient, but there are so many patients who are unfit for epidural or spinal anesthesia. And when they write this to me, they write this to a patient who got ejection fraction 30%, who barely have got systolic blood pressure of 80 milliliter mercury, and they will send a note to the patient, this patient is not for GA fit for epidural. Then I need an hour and a half to convince the patient and family he is not fit, although his doctor told him, go to the anesthetist and tell him, I haven't got one size fits all. Each patient, I have to tailor anesthetic for each specific patient. As I mentioned, our anesthetic drugs nowadays are really, really good and safe and smart. But to avoid vasoconstriction, I have to mention this because with epidural and spinal anesthesia, 100% possibility, you've got 100% chance to drop your blood pressure. And these patients, if it wasn't, I've done so many sclerodermas, not for neurosurgery. When blood pressure goes down and she's got Reynolds, she's got vasoconstriction already, I have to even vasoconstrict her even further. And with that, I lose the problem of monitoring. Pulse oximeter does not pick up. I don't know what's the situation of her oxygen. Is she good or not? It's really a nightmare just to find any place to measure her oxygen. That's why I need as well an arterial line. Sometimes because the pulse oximeter is not reliable, I have to check repeated serial pulse oximeter ABGs to find out what her oxygen looks like. Potential for hypoxemia in these patients because all of them, almost all of them, they will end up with lung problems, especially at this later stage. Post-op ventilation, I'm going to ask all my colleagues, please, to avoid post-op ventilation because they are prone to barotrauma so easily. And that's why you have to make the ventilation ratio inverse, make it 2 to 1 instead of 1 to 2, because these patients are so frail, their lung is fibrosed, and if you leave the normal ratio 1 to 2, that you are prone to barotrauma. I have to use all possible means to extubate them at the end of the surgery. I can't go home, rest, and leave the patient intensive care overnight, all night, and positive ventilation. Then I will come this next day morning, undoubtedly she will end up with barotrauma. Disease has been spoken a lot about it, but what I'd like to mention the pulmonary CREST syndrome. It's most of the time is there. Interstitial lung disease reported to occur up to 80%, so almost 8 out of 10 patients, they've got some sort of respiratory. I will take them for my anesthetics and scleroderma, reaching to me to that stage of good respiratory involvement. That's why I have to take care for ventilation, intra-op ventilation, and post-op ventilation. Majority of patients lung as well, clinically significant interstitial lung disease is, you see it only in 40%. Otherwise, it's silent and you don't see it clinically. So probably lung function test is quite advisable. It's quite good to tell you what sort of restrictive lung disease you've got. And how much is the values of lung volumes. Gastrointestinal has been mentioned. 75% are involved. Gastric reflux is there, and it's a threat for me at all times. The other thing is cardiac, and it's multi-system disease, has been explained, has been mentioned by my previous colleagues. All of them is there, and the myocardium is involved in up to 50% of patients. They are prone to arrhythmias. They are prone to some sort of blocks, whether it's uniblock or bilateral block, complete block, or even sclerosis of coronary arteries, which you don't see, but is there. And I feel sometimes this sclerosis of arteries and veins, while I'm doing my lines, I mean, you could tell, really, you could see it in ultrasound. All veins, our arteries, most of the time are sclerosed, and they are very tough, and sometimes even you need a good needle to go through. Renal is a problem, and if we got a patient whose kidney is not very well all the time, for me, is a threat, especially in long cases, neurosurgical cases. Endocrine, I'm not going to mention. Drug therapy, she was a load of drug therapy. Now, preoperatively, I would guess you should know about your patient. We should know about the disease itself before we embark and say and write for Dr. Ibrahim, she is fit for GA. We have to see the patient. I've seen the patient a couple of days before. I remember 3 days before the surgery. They must have experience and background about these cases. What is involved? What system are involved? To ask for a proper test, echocardiograph, to see the ejection fraction with the myocardium is involved, to see the pulmonary function test, as I said. The fact that every aspect of surgical anesthetic may alter, hindered by pathogenesis of this disease. Everything is altered and forgotten. Routine investigation was done, chest X-ray was done, although chest X-ray, as Dr. Azmi has mentioned, we've taken it in our books in anesthesia. Any esophageal dilatation, that just means the chest is involved for us. And that's, we take it as a rule of thumb. Any esophageal, any regurgitation, any esophageal, I think this is safe. I would advise my fellow colleagues to take it as to avoid aspiration, because these patients with fibrosis, with a bit of aspiration, that's it, that recipe for death, 100% is death. Proper history to be taken, how long it's been, and then anatomical changes to see neck mobility, opening of the mouth, as Dr. Naddaf mentioned, 2 fingers, 3 fingers, and if I've got in my tools, if I've got the fiber optic or the means to intubate this lady. Intraoperative, it's always, as I said, fiber optics were there. It was we did intubate this lady. Invasive monitoring, they were required. It's lung surgery, it's a brain surgery. She was about to be almost coning. So I need invasive, as I said, doing especially arterial line and radial artery. You have to think twice whether you're going to do it or not. If it's a simple surgery, an hour or less, probably I won't do it. Although non-invasive monitoring in these ladies is not going to be easy. I've tried them. Most of the time, blood pressure does not read, and it takes time, but sometimes more than 5–10 minutes just to realize the blood pressure is down in her boots. So arterial, you have to think, but long surgeries, definitely you need an arterial non-invasive. The fluids, they need just about right fluid, and position sometimes is a problem, especially if you are sitting position. With these sclerotic arteries, sometimes they will end up with obstruction and kinking of the blood vessels and lymphedema at the end of the surgery. You will find very large legs, so it's a problem. So in conclusion, patients with scleroderma present a challenge, the challenge for anesthesiologist, pleasant for surgeon, but I think a multidisciplinary approach is always advisable, and you will reach safely with the surgeon and with the other physician. Thank you.
So what's the take messages from all what we have here? I want to allude to the so-called package deal, which is a practice in Jordan and in this part of the world, where the surgeon would take, say, 5,000 JDs and tell the patient, I will cover everything and cover my fees and the hospital fees. Would anybody in his own mind think that the surgeon is gonna do that? Gonna do all these tests? Admit the patient 3 days before and ask the endocrinologist and the rheumatologist and the cardiologist and the anesthetist to see. I doubt it. So I'm totally against the package deal, and it should be finished. Second thing is to put a patient on a ventilator. There is this trend in Jordan and in this part of the world. It says the consultant will tell his residents, we will put the patient to rest, leave him to rest overnight. It's a long surgery. Let him rest. This is, I can't describe it. This is criminal. It is not described in any book. It is only described in their filthy mind. They just want people not to know what's the result of their surgery. The third is the jack of all trades is master of none. You cannot know all these factors, all this knowledge. So it's the teamwork rather than single person work. And before I proceed to the surgery, I would ask our radiologist, what do you think this lesion is?
I think that this is this interaxial lesion, not extraaxial. With the appearance, I put a differential. I put on top of them the factor of the scleroderma, but the interaxial, I cannot exclude one of the tumors which you mentioned.
Sure.
Thank you. First of all, I have to keep in mind the history of the patient in order to put scleroderma vasculitis in my differential diagnosis. Otherwise, it's very difficult. Other things is the gliomas give this appearance of some secondary arachnoid cyst. This likely to be an abscess because there is no restrictive pattern in WI. This my differential. But the one I want to mention that I have to do in this situation perfusion and spectroscopy and can reach 90% of the differences.
Thank you. Okay, anybody want to make any comment?
Yeah. How long
Please.
is this process? I mean, this is a really big thing. How
Yes.
long did that process in your opinion take?
She gave us about a month history of this deterioration. Just a month history. And that's the magic of the brain. Brain can tolerate and then things go suddenly. Most of the patients that I've seen with tumors like 10, 11 centimeters in diameter, you ask them and they say, oh, last week. So this, because it's slowly growing, they can tolerate. If it is fast growing, like in glioma, it can happen quickly. But in this particular patient, within 1 month. So this is the consent form, the detailed consent form that we usually do. We say the frontal lesion because I don't know what that is. And I have to tell the patient all the details. This is tailored to the patient. There is no general consent form. And I spell the complications in details. When I say 10%, they say, oh, 90% is good, so 10% is small. I say, your patient could be one of the 10 who can die during surgery. So I have to spell it. Yes, it is 100% in that case. Surgery, let's see the surgery. I will not disclose what's the lesion. I will leave that to Dr. Hassan after we finish the, and I hope Hassan will keep the secret till the end. So, just to show you that this tumor is vascular. This is the message here. This is a vascular tumor. And I'm attacking the solid parts. The cystic part is easy. So I'm using the ultrasonic aspirator to take the tumor out.
Do you have a capsule?
In some areas, yes, in others, no. Here, for example, there is a capsule here. So you pick up the blood vessels of the tumor. Usual way of debulking from inside and then going around it.
Was there any pressure when you opened the stump?
Was there what?
Any pressure?
Of course, it was severe pressure. That's why I opened the dual limited opening, because if I open full, the whole brain will come out and I cannot put it back.
Wow.
And usually the surgeons blame the anesthetist for this. Oh, there's severe edema, put the head up, give mannitol. It's not. It's not the problem of the anesthetist. It is the problem of the tumor. So the best thing to do is to go and try to remove this tumor as soon as possible. You can see a limited opening. So this is where the cyst was.
What are you removing now?
I'm removing the tumor.
Oh.
This is the tumor.
So there's actually. Yeah.
Or the lesion, call it lesion if you like. This is where the cyst was, the cavity of the cyst, and then we do hemostasis and go out. Okay.
That white thing is the brain, huh?
The brain where the cyst was.
Yeah.
Okay. Dr. Hassan, keep the secret and then.
Good evening.
This is cytology of the fluid.
Okay. I think the CSF, there wasn't much in the CSF. No. Only blood inflammatory cells. This is the tumor, and actually it is a tumor. You can see that it is cellular and it is a diffuse process. There is no pattern. The cells are not arranged like in a specific pattern. So this is a diffuse tumor, and you can see that the majority of cells, they have a very clear cytoplasm. There might be some pleomorphism. See, this nucleus is very large and irregular compared to the other tumor cells. So the tumor has cells with clear cytoplasm, which raise the possibility of metastasis, actually. And this is how our view, just to show you the clear cytoplasm of these tumor cells. Differential diagnosis, when you have clear cells, tumors in the central nervous system, will include, of course, metastasis from renal cell carcinoma, clear cell variant of meningioma, and other tumors as well. You can also think about hemangioblastoma, because hemangioblastoma, they have vacuolated clear cytoplasm. So we have, I think we have, again, you can see that it's all the same. The cells are vacuolated with clear cytoplasm, and they have those nuclei that are quite variable in size. But there wasn't much in the way of mitosis or necrosis in this tumor. Now, this is the interface between the tumor here at the top, and this is the normal brain tissue, and you can see some neurons here. So it is not invasive. It has a well-defined border. Next one. There were some cystic areas. Dr. Ibrahim mentioned that part of the tumor was cystic, and you can see the beginning of these microcysts here. This is a degenerative change also. There were some peculiar fibers among the tumor cells, so-called amianthoid-like fibers. And they look like what we call fibrillary asbestos or things like that. Now, it is characteristic of a specific type of brain tumors. Actually, it is also mentioned in that these things could be seen in meningiomas, clear cell meningiomas in particular. So we did immune markers just to make sure. This is an epithelial membrane antigen, and it is a marker for the, it's not specific, but it is positive usually in meningiomas. And you can see that these tumor cells are taking the stain. The brownish staining around the peri, or so-called membranous pattern of staining, is seen in meningiomas usually. And this is strong positive stain. We did also cytokeratin because we have to rule out renal cell carcinoma, and you can see it's all negative. There is no brown pigment here. They did the Ki-67 proliferative index, and you can see that the tumor has very low proliferative index, around 1 or 2%, not more than that. These brown nuclei are the ones that are positive, and the other ones, they are not in a proliferative phase. So it is not actively proliferating tumor. So actually, we called it a typical meningioma.
because of two things. First of all, is the increased no, it is not the increased mitotic activity in this case. The diffuse growth pattern, and by default, when you have a meningioma with clear cytoplasm or so-called clear cell meningioma, this is considered grade 2 meningioma, which is a typical meningioma. And that's based on that way. Even though that we didn't have mitotic activity or high proliferative index, but this can happen. And here we have increased cellularity. We have diffuse growth pattern or patternless sheath, growth-like pattern, and we didn't have the other features like the mitosis, the necrosis, or the prominent nucleoli. And these are variants of atypical meningiomas, chordoid meningioma and clear cell meningioma, and in our case, it is clear cell meningioma.
Thank you very much. So the histology is grade 2 meningioma. I just want to remember something. The other day, I hear that one of the candidates for the Jordanian board described me as unfair because I asked him about meningiomas. Meningioma constitute 20% of brain tumors. 20%. The tetraadenomas, another 18%. Gliomas and metastases, etc., about 45, 50%. So if you ask a candidate who finished his 6-year training about grades of meningioma, this is the first-year question. These people, they want us to ask them about head injury, about Verhul, about a shunt, and then give them certificates. And I believe these certificates are certificates to kill, not to practice medicine. So, the post-operative course, woke up on table. No patient should leave on a ventilator.
Especially this one.
Especially this one, with all the problems that she has. Don't believe anybody telling you, keep the patient on a ventilator. This is out of their stupid minds. It does not exist in medicine. Except if I'm putting patient in Parby-Tritz coma for one reason or the other, like in head injuries. MRI the following morning, not go home without MRI to hide whatever the surgeon has done. Again, this is a trend that we have to fight. And when they do image, they do CT scan, they don't do MRI. So this is immediate post-operative images. You can see some post-operative changes. Shift is getting less because we are seeing the ventricle. This is the following day. So this is what we saw the following day. You can see the shift in the line is less. So we saved their life. And we did complete excision of whatever that lesion is, because when we removed it, we did not know what it is. Be it a meningioma or a scleroderma lesion or whatever, it has to be removed completely. Don't believe them when they say take a biopsy and give radiotherapy. This is another crime practiced in this part of the world. So she was discharged on the 5th postoperative day, and we referred her for radiotherapy. Why? Because my finding during surgery that there is ill-defined borders, and the second that this is a grade 2. And with the grade 2 in this size and this ill-defined borders, I referred her for radiotherapy, which she had. She had 54 rays radiation. And this is the lady, her facial weakness has improved. No facial weakness anymore. There she is. She went back to her husband and children. 3 years follow-up. Actually, she missed last follow-up. So I sent my secretary, Ahmed, to seek her husband to see where she is. And he told us that she had MRI in Al-Bashir Hospital, but he does not have it. He is leaving for whatever. So we sent Ahmed to Al-Bashir Hospital, got her MRI, which I brought it to you. This is the 3-year follow-up of this lady. This is how you have to keep the recording these cases and documenting it. So this is the postoperative MRI. Any questions, any comments?
Thanks, Doc.
Pleasure. Any questions? Any comments?
Yeah, the comment is no correlation between the two things.
Yes, but
Meningioma is not
it's not absolutely. That's the message. But how to deal with such a case? That's why we put it. It's multidisciplinary. You have to be broad-minded and think all
We have a
types.
child with scleroderma. When should we do an MRI?
It is said that brain involvement happens between 20 to 50% of patients with the scleroderma. So if he has any symptoms, I advise.
Just to have symptoms.
Yes, yes. If it does not, it is not. Yes, as a screening, especially in children, because they are commoner in this type of tumors and things. Okay, with this, please, question?
Yes.
If we did spectroscopy for this patient, we will find alanine at 1.5, which is very helpful to go toward the meningioma.
Thank you very much. We'll see you next week. Somebody has arranged.
We have to.
Hello.
Yeah, hi, Dr. Zubey. How are you today?
I'm fine, thank you very much.
Okay, thank you very much. We have panelists from various places. Let's see who's here. Can we introduce the panelists to Dr. Zubey? Musindo or Ali or Abdul? Go ahead. Just go ahead and introduce yourself. Go ahead, Musindo. I think you know Musindo from Zimbabwe. Hello, Musindo. Are you there? Okay, I'm sorry about this. This is a weakness of this platform. Ali, could you please introduce yourself? Ali, are you there? Oh, go ahead, Ali. Go ahead, Ali. Oh, come on, Ali. Come on. Come on. Oh man, well, I'm not having success. Abdul, are you there? I'm gonna unmute you, Abdul. Go ahead. Go ahead. I'm not having any luck here, Dr. Zubey. Ever have one of those days?
It's all right.
Okay. Ziad, are you there? Ziad, okay. I guess we're not having any feedback from the panelists. They're there.
The most important thing is that I hope that they have enjoyed the lecture, and that's my aim of.
There you go. Yeah. There you go. Well, you know, we had 8 panelists at one time, so the interest is there. And you are broadcasting to, like you said, to all over the world. I mean, potentially. Sure. And we appreciate you exploring the platform with us. And a lot of people don't realize that the setup you have there is not an expensive setup. You don't have a big camera. You don't have a big, you just have a laptop, a webcam, and good connections and a good technician, which makes it fairly simple to do what you're doing.
Absolutely. But you have to have a material which is worth presenting to people. And that is the work of so many years of preparation and organizing these photos and things like that. And I want to allude to what you have said, that we are in the age of telemedicine or audio conferences, because to travel long and far and with all this happening like coronavirus and the others, exactly. I think the video age is there.
Yes, I can see it's getting more in demand. We just did one from London on coronavirus 2 days ago, and there was a lot of interest, obviously, for people that can't get around. And I'm approaching Chinese neurosurgeons now to say, hey, you guys, we can do teleconferences. You don't have to go in it. Because imagine in a place like China, their movement of neurosurgeons is very restricted.
Sure.
And all those conferences were probably canceled. In that area. Are there any restrictions yet in Jordan at all, or have you seen any effect?
No, we did not have any case, luckily, so far, and we are just keeping an eye, but we don't have a case, and hopefully we will continue the same.
Okay, very good. Do you have a topic yet for next week?
Yes, we will present bullet injuries in sort of, not war injuries, but sort of non-war injuries.
Missile injuries of the head, etc.
The head, yes.
Enjoy. Okay, very good. Thank you, doctor. You have a good week. We'll see you next week.
Thank you. The same to you. Thank you very much.
Bye-bye.